reaction in allergic reaction, that is immunoglobulin A. So that is going to bind with mast cells, and on the subsequent exposure, there is antigen antibody reaction and it will rupture the mast cell. And this rupturing of mast cell will lead to release of different mediators. And these are the mediators which are responsible to promote process of inflammation, right? And the hallmark of asthma is bronchial hyperreactivity to endogenous or exogenous stimuli. This is important. In asthmatic patient, the response to various stimuli is amplified by persistent inflammation. Right? So, in asthma, what happens? Already we have discussed that in asthma there is reversible episode of bronchoconstriction. That means narrowing of the diameter. When there is narrowing of the diameter of the lumen, what will happen? What will happen? Difficulty in breathing, right? Difficulty in breathing. So that is why the most important treatment option in asthma to reverse the bronchoconstriction, to dilate the lumen. So there will be improved airflow. So this is how we can overcome the difficulty in breathing. So what happens? So you can see in this slide, in asthma, the effective diameter of the airways is decreased. The goal of therapy is to decrease airway resistance. And the main point is increasing the diameter of the bronchi. And number two, decreasing mucus secretion or stagnation in the airways. That is another mechanism that is responsible to hinder the normal air flow, right? So now come to the pharmacology. The goal of therapy is to, on top, first we'll have to reverse the bronchoconstriction. That is our main task, right? So we can overcome the problem related to breathing, that is difficulty in breathing. And if you try to recall, to what are the drugs that can relaxes the bronchial smooth muscle? And this is very important. The drug or group of first choice to reverses the bronchoconstriction is the sympathetomimetic drug, or we can also say adrenergic agonist. Adrenergic agonist. When we say adrenergic agonist, that means the drugs that are responsible to stimulate sympathetic nervous system, right? So if we will further explain, this adrenergic agonist, first we must know, when we say adrenergic nervous system, we have different receptors, right? Alpha receptors, right? Number two, beta receptors. So more specifically, for bronchodilation, which receptor is required to stimulate? Alpha 1, alpha 2, beta 1, beta 2. So more specifically, which receptor stimulation is required? That is beta 2. So we can say beta 2 adrenergic agonist drugs are required to relaxes the bronchial smooth muscles. So this is how we can improve or increase the diameter of the lumen. Okay, so this is the picture. You can see picture A, right on the left side. Muscle of bronchi are relaxed, allowing easy airflow. You can see. But in portion B, muscles of bronchi are tight and thickened. The bronchi are inflamed and filled with mucus, which impedes airflow. Right? So, when there is constriction, there is difficulty in breathing. Already we have this. So that means in the beginning, already I have discussed that inflammation takes a key role, right? So first of all, we have to reverse the bronchoconstriction, and ultimately will have to stop the process of inflammation to avoid the recurrent bronchoconstriction. Because if we are not going to stop process of inflammation, okay, we are using bronchodilators. At that time, we reverses the bronchoconstriction, but again, this episode can occur because we haven't subsided or stopped the process of inflammation, which is responsible for this further process of bronchoconstriction phenomena or the bronchial hyperreactivity. So now the treatment option. So again, I am repeating, due to process of inflammation, due to antigen antibody reaction, mediators are released, stimulation of process of inflammation. The most important clinical picture is the bronchoconstriction. So first, we'll have to reverse the bronchoconstriction. And this we can achieve by giving adrenergic agonist, beta-2-adrenergic agonist, and we can classify this group under the heading of quick relief medication because the main mechanism, that is the inflammation, right? And due to this inflammation and allergic reaction, there is bronchoconstriction. So first we'll have to reverse the bronchoconstriction so we can improve the airflow. That we are going to achieve by giving quick relief medication. And long-term control medication, what does it mean? Already I told you, until unless we are going to stop the process of inflammation, this recurrences of episodic bronchoconstriction will continue. So we can classify anti-asthmatic drug into quick relief medication in which we are going to produce bronchodilatation. And in long-term control medication, the main objective would be to stop the process of inflammation. So we are going to use anti-inflammatory drugs. Okay? Drugs for asthma, again, already we have discussed two major groups. First group labeled as bronchodilators, and drugs which are included in this group, they are going to produce relaxation of the bronchial sphincter, so it will dilate the lumen of the bronchial. And second one is the anti-inflammatory drugs. So these are the two major groups of drugs that we use in the treatment of asthma. So strategies of the therapy: acute asthmatic bronchospasm. Already I have given you the clue about this acute attack. Bronchospasm must be treated promptly and effectively with bronchodilators, what we label as reliever drugs, quick relief medication. And what you must know, most commonly, or drug of first choice as bronchodilator belongs to beta 2 agon. Beta 2 agon. That means drugs, they are going to stimulate beta 2 receptors, resulting in bronchodilation due to relaxation of the bronchial. And second group is the muscarinic antagonist, or we can say anti-muscarinic drug, right? Because if you just try to recall, when we say autonomic nervous system, we have a sympathetic nervous system and we have parasympathetic, right? The stimulation of sympathetic nervous system is responsible to produce important neurotransmitter like norepinephrine and epinephrine, and receptors which are involved: alpha 1, alpha 2, beta 1, beta 2. And stimulation of beta 2 is responsible to produce relaxation of muscle and especially But when there is a stimulation of parasympathetic nerve, in which we have different receptors like nicotinic receptors and muscarinic receptors. Stimulation of parasympathetic nervous system is responsible to produce bronchoconstriction due to contraction of the smooth muscle. So, in this situation, we are required the anti-muscarinic drugs, the drugs that block the muscarinic receptors, because when there is stimulation of muscarinic receptors, that in parasympathetic nervous system, it will increase the contraction of the bronchial smooth muscles. So we are required the blocking activity of this muscarinic. So that is why we are using anti-muscarinic drugs, or we can say muscarinic antagonists. This is the explanation of this second group, that is the muscarinic antagonist. And the third one that belongs to methylxanthine group, and the important example is theophylline and its derivatives. But important point that you must remember: clinically, we are not using commonly theophylline as a quick relief medication or in the treatment of acute asthma. There are some specific indications that we will discuss that go on, but this drug is not labeled as the drug of first choice. The drug of first choice to reverse the acute bronchospasm, always remember that belongs to B2 agonist. The second group, muscarinic antagonist, and the third group, which is we are not using commonly nowadays in the current clinical practice, that is theophylline and its derivatives. Right? Now, bronchodilators. So already we have discussed two major problems: bronchoconstriction, inflammation. So we are producing bronchodilation by giving bronchodilators, and we have to use the anti-inflammatory. The bronchodilators, the major group that already we have discussed, sympathomimetics, right? And in sympathomimetic, more specifically, selective beta-2-adrenergic agents. Right? So there are some non-selective drugs as well. Non-selective means drugs that we are using responsible to produces bronchodilation by stimulating beta. But non-selectivity means it's going to stimulate all the receptors like alpha 1, alpha 2, beta 1, beta 2. So other effects that can be produced due to the stimulation of alpha 1, alpha 2, and beta 1, that we are going to achieve. So that is why we use specific selective beta-2-adrenergic agonists. Right? Second group, already we have discussed anti-muscarinics. They are going to produce bronchodilation by blocking muscarinic receptors. The third group is the methylxanthine. The important example is the theophylline. And the next group is the B-Adrenergic receptor. Right? So this is very important to know. This leukotriene receptor antagonist has dual activity. It's not only going to produce bronchodilation, but it also produces anti-inflammatory activity. And in the subsequent slides, we will discuss in very much detail. So don't confuse right now related to this leukotriene receptor antagonist, right? But at this moment, you must remember this group has dual activity. What does it mean, dual activity? Because already we have discussed two important mechanisms: bronchoconstriction and inflammation. We are required bronchodilators, we are required anti-inflammatory drugs, right? So this leukotriene receptor antagonist produces bronchodilation as well as can produces anti-inflammatory activity. But what you must remember, clinically we are not using B-Adrenergic receptor antagonist as bronchodilator. We are using this group as long-term control medication. But because it produces bronchodilators, that is why I have mentioned over here. Now, long-term preventive treatment required. Why it is required? Why it is required? Already I told you. Because if we are not going to stop the process of inflammation, this recurrent episode of bronchoconstriction will continue. So that is why first, if the bronchospasm has occurred, the first or most important point is to reverse the bronchospasm by using bronchodilators. But our main focus should be to stop the process of inflammation. So this is how we can stop the recurrence, right? So that is why we use the term long-term control medication. So long-term preventive treatment. So that is why it is labeled as the preventive treatment, right? Because we are going to prevent the recurrent attack or recurrent episode of bronchitis. So long-term preventive treatment requires control of the inflammatory process in the air. So that is why we are labeling as controller drugs. And the most important anti-inflammatory drugs in the treatment of chronic asthma are the corticosteroids. Corticosteroids. So two important points, again I am repeating. To reverse the bronchospasm, normally in acute attack, the drug of first choice or group of first choice is B2-adrenergic agonists, right? And to control the process of inflammation, the group of first choice would be corticosteroids. Right? Other drug as well, other group as well we are going to discuss. But the most important anti-inflammatory drugs or anti-inflammatory drugs we use as long-term control medication, right? To prevent the future. So again, I am repeating the most important anti-inflammatory drugs in the treatment of chronic asthma are the corticosteroids and drugs such as bromelain, sodium, and nitrocromil, also labeled as the mast cell stabilizers. That means they are going to prevent the release of mediators in response to antibody attachment and antigen antibody reaction and rupture of mast cells. So this rupturing phenomena can be prevented by using mast cell stabilizers. And we have examples bromelain sodium and nitrocromil and how they are going to prevent the release of mediators that we will discuss in the subsequent. Number one choice in the as long-term control medication, corticosteroids. Okay. Second point, second important drug that is the again beta-2 agonist, right? But when we use beta-2 agonists as long-term control medication, definitely we are going to use the long-acting beta-2 agonist. Yeah, because short acting that we use in the treatment of acute attack. So I think the difference between short acting drug and long acting drug. Short acting drug onset of action is rapid, but duration of action is shorter. So that is why we are using in acute episode. And long acting drug means onset of action is slower. It takes time to initiate a response, but it will produce the persistent effect. It will produce the effect for a longer duration of time. So, in the long-term control medication, first choice is the corticosteroid. The second is the long-acting beta-2-adrenergic agonist. Anti-immunoglobulin E antibodies also appear promising for chronic therapy. Then the leukotriene antagonists have effect on both bronchoconstriction and inflammation, but are used only for prophylaxis, that we use as long-term control medication. Already I told you this point. Right? So anti-inflammatory drugs, bronchodilators, antithymometics, specifically beta-2-adrenergic agonists, anti-muscarinics, methylxanthine, right? And when we say anti-inflammatory drugs, on top, first choice is the corticosteroids, then mast stabilizers, and the third one is the anti-immunoglobulin antibody. And we can add another group that is the leukotriene receptor antagonist. Now, one by one, in acute attack, the drug of first choice or group of first choice is the beta-adrenergic agonist. It's the static nervous system. In adrenergic nervous system, we have different alpha 1, alpha 2, beta 1, beta 2. So, more specifically, uh, when still bronchodilation occur when there is stimulation of beta 2 adrenals. So, we can say more specifically beta 2 adrenergic agonist. The general characteristics: adrenergic agonists stimulate B-Adrenoceptors. What will happen due to stimulation of this receptor? Relaxation of bronchus. And it also inhibits the release of mediators. It stimulates mucociliary clearance, but the main mechanism of action is to relax the bronchial. Adrenergic agonists, they are useful for the treatment of acute bronchoconstriction, right? These agents are used both for quick relief and for long-term control, depending on biologic pathway. What does it mean? What is it? In acute attack, we are required the quick response. This we can achieve by using short-acting beta because already we have discussed short-acting means they have rapid onset of action, right? But duration of action is shorter. But our main purpose is to reverse the bronchoconstriction as early as possible. That we are going to achieve by using short-acting beta-2-adrenergic agonists. That is why in emergency situation, what you must remember, beta-2-adrenergic agonist group is supposed to be the group of first choice. Beta-2-adrenergic agonist that we are going to prefer. Clear? And long-acting, definitely long-acting, we can use beta-2-adrenergic agonist in the long-term control medication to prevent the relapses. But one important point I want to share here with you. In acute attack, this group is supposed to be the group of first choice. But when we use this group as long-term control medication, this group is not preferred because in that situation, in long-term control situation, the group of first choice would be anti-inflammatory group. That is corticosteroid. Clear? This long-acting is going to be helpful if we use along with corticosteroid. Clear? The most important sympathomimetics used to reverse asthmatic bronchitis. What you must remember. Important example, right? So already we have discussed. Beta-2-adrenergic agonist responsible to reverse the bronchoconstriction, right? That we know. But what are the examples? What are the drugs that can produce this activity? And examples are albuterol. And this albuterol is also called solvital. Same thing, right? Second example is terbinafine, and the third example is the methamphetamine. These are shorten and are the most important agents. If I'm going to label, okay, which one is being used commonly in the clinical practice, that is albuterol, right? So we can also use sertraline and metoprolol, but in our clinical setup, the most common example is albuterol. Clear? And the solmetrol and formoterol, these are the examples of long-acting beta-2 selective agonists. Already, I told you selective agonist. What does it mean? Because this drug specifically stimulates beta 2. This drug is not going to, or this group is not going to stimulate alpha 1, alpha 2, and beta 1. Right? So, this is the general concept. Right? Okay. Now, short acting beta 2 adrenoceptor agonist. Okay. When we are going to use this short acting beta 2 adrenoceptor agonist, inacute attack. Inacute. Okay? And examples albuterol, levalbuterol, perbuterol, metoprolol, and the administration. How we are going to administer? By inhalation. Onset of action is 1 to 5 minutes. That should be because we have to reverse the bronchoconstriction as early as possible. And available oral preparations, okay, this albuterol not only be given so by inhalational route, inhalational preparation of albuterol is available, but also its oral preparation is also available. And albuterol and terbutaline, these are the two preparations that can be given orally when we use as long-term control medication. Because definitely in emergency situation, we are required the inhalational route. Yeah? So, because when we use inhalational, this drug directly, directly administered into the bronchial tree, right? Site of action, which is site of action. So, this is how we can achieve the earliest response. But long-term use of these agents, now this is important. Long-term use of these agents for the treatment of chronic asthma has been associated with diminished control, what we label as tolerance, right? Tolerance, decreased drug response, that is called tolerance, perhaps due to beta receptor downregulation. So, suppose if this problem occurs, patient is not responding, right, or showing the tolerance, what we can, how we can overcome. Generally, if number one, either we stop the drug or drug interval, drug holiday, because when there is no exposure of drug on that receptor can be reactivated, right? And second phenomena is to increase the dose, right? But in this situation, what will happen if we are going to increase the dose? Increase chances of side effects, increase chances of adverse effects, right? So in that situation, what comes in your mind? Now, how we can solve this problem? Because we cannot leave our patient without any drug. So in that situation, we can try another drug that can reversibly stop. So beta-adrenergic agonist, long-acting that we use as a long-term control medication. Important example, solmetrol and formoterol. Also administered as inhalant, but have a slower onset of action, but longer duration of action. These agents are very effective for prophylaxis of asthma. but should not be used to treat an acute. Why? Because long-acting drugs slow onset of action. Slow onset of action. So that is why it cannot be used in acute. And simple mechanism, what we have discussed until now, beta-adrenergic agonists, okay, they are, because they are agonists, so they are going to stimulate the beta-2 receptor and it's going to produce the bronchodilation. But more specific, how this relaxation happens. When there is stimulation of beta-2 receptor, it will increase production of cyclic AMP. It increases the level of cyclic AMP, right? And this increased level of cyclic AMP is responsible to produce the relaxation of the bronchial. It also inhibits the release of inflammatory, but the main mechanism related to beta-2 receptor stimulation is the relaxation of bronchial muscle. How? By increasing cyclic AMP level, and this increased level of cyclic AMP results due to stimulation of adenyl cyclase enzyme. Now, this is another way to explain this mechanism. You can see in this slide, right? The round box that is, you can see the beta agonist. So, this beta agonist, there is a plus sign, is going to stimulate, what does it mean? AC, adenyl cyclase. So it stimulates adenyl cyclase enzyme, and stimulation of this adenyl cyclase enzyme will lead to increased production of cyclic AMP. And this increased level of cyclic AMP more specifically responsible to produce bronchodilation. Clear? So this is the mechanism of action of beta-2-adrenergic agonists. Important examples are albuterol, terbutaline, metoprolol. These are the examples of short-acting beta-2-adrenergic agonists that we use in acute attack. And what are the examples of long-acting beta-2-adrenergic agonists? Formoterol and albuterol. Right? Other agents, okay, because already we have discussed the sympathetic nervous system or adrenergic agonists. Other drugs, you just know the name, like isoproterenol, epinephrine, ephedrine. These were specifically ephedrine, very much older drug, but in current clinical practice, we are not using these drugs. But you must know the mechanism. Why we are not using these drugs in current clinical practice. For example, isoproterenol. Isoproterenol can be used to reverse the bronchoconstriction by stimulating bronchodilation, relaxes bronchial muscle by stimulating beta-2 receptor, but it's a non-selective beta receptor agonist. What does it mean? It not only stimulates beta-2 receptor, which is required for the bronchodilation, but it also stimulates beta-1 receptor. Right? So, what will happen? So what? This is another question that will definitely arises in your mind. So what? We are achieving the bronchodilation due to stimulation of beta-2 receptor. Okay, if it's going to stimulate beta-1, so what? Is there any problem? Yes, there could be a problem because beta-1 receptor more specifically present on heart. Commonly, major receptors which are located in the heart, beta-1. When there is stimulation of beta-1 receptor, increase cardiac activity. So why you are going to increase or stimulate cardiac activity unnecessarily? Right? If you have specific beta-2 adrenergic agonist available, there is no need to use this even though it's a very potent bronchodilator. We are not going to take any kind of risk. Second important drug, okay, this is very important. Epinephrine. Epinephrine, it's going to stimulate all the adrenergic receptors. Alpha 1, alpha 2, beta 1, beta 2. Again, for conceptual point already we have discussed, because it's going to stimulate beta 2 receptor. Okay, we can use to reverse the bronchoconstriction, but generally we are not using this epinephrine in the treatment of that. Its use is only, this is important point, because this epinephrine is supposed to be the drug of first choice if there is shock due to anaphylactic reaction. You know, anaphylactic reaction is due to antigen antibody reaction. So in anaphylactic shock, you know, shock means heart is unable to pump the blood. So, and in anaphylactic reaction, and this anaphylactic reaction due to antigen antibody reaction, when there is antigen antibody reaction, right? So what will happen? Bronchoconstriction will happen. So this epinephrine, why it is supposed to be the drug of first choice? Because it not only increases the cardiac activity by stimulating alpha 1 and beta 1 receptor, and also responsible to produce bronchodilation due to stimulation of beta 2. Ephedrine is a relatively non-selective beta and alpha 1 adrenoceptor agonist, rarely used in the treatment of asthma. The reason is same, because of non-selectivity. When we have used other drugs. Now, the adverse effects of this very important group, adrenergic agonist, skeletal muscle tremor is the common adverse beta 2 effect. This is the general side effects of adrenergic agonist. Beta 2 selectivity is relative. What does it mean? This is important. Okay, generally we say selective beta 2 agonist, but this selectivity is relative. What does it mean? This selectivity is not absolute, relative. What does it mean? If we use the beta 2 selective drug in high doses, so generally these beta 2 selective drugs can also stimulate beta 1, right? So in that situation, what will happen? You know, already I told you stimulation of beta 1 receptor will lead to stimulate cardiac. An important cardiac effect that is tachycardia that can happen. Other adverse effects are rare. Agents are used excessively, arrhythmias may occur again. I have explained, because when we use the high doses or we use for a prolonged period of time, it can also stimulate beta 1 receptor that may lead to increased cardiac activity that will lead to arrhythmia. This point already we have discussed. Loss of responsiveness, like tolerance, like tachyphylaxis, that is an unwanted effect of excessive use of the short-acting sedatomimetics. Okay, I am just watching that of the students, they are raising their hands, but that means they just won't pass the question. But at the end of the lecture, I'm going to use the answer of your question. So please, at this level, note it down on the copy or any notebook. So at the end of the session, definitely, inshallah, we will discuss the different questions that were. So loss of responsiveness, in this slide you can see there are two terms that we are using, tolerance and tachyphylaxis. So there is a slight difference. Mechanism same. When we say tolerance or tachyphylaxis, decreased drug response. But when we say tolerance tolerance, that is the gradual decrease in drug response. When we say tachyphylaxis, rapid decrease in drug response. That is for the tachyphylaxis. Now, second group, muscarinic antagonists or anti-muscarinic drugs. So examples that you must muscarinic antagonists include ipratropium bromide and tiotropium. These are two important examples that you must remember. What is the difference? This is important point that can be asked. Ipratropium, that is the short-acting anti-muscarinic drugs, and tiotropium, longer. So one point is clear. Which one can be used in acute recovery? Okay, ipratropium. Why? Because it's short-acting. So, because short-acting can produce the rapid onset effect. Very good. This is important. Tiotropium that we use as a long-term control medication. So how it's going to produce this? Ipratropium and tiotropium competitively block muscarinic receptors in the airways and effectively prevent bronchoconstriction mediated by vagal discharge. Anticholinergics, this is an important point, decrease mucus secretion. Activity controls the secretion, enhances the secretion. So when we block muscarinic activity, not only we are going to reverse the bronchoconstriction, but also decreases the secretion. Okay? They are useful in patients who are refractory to or intolerant of sympathomimetics or methane. Right? The drug is delivered to the airways by pressurized aerosol and has little systemic action. In contrast to beta-2 agonists, muscarinic antagonists do not cause tremor or arrhythmia. So one important point I can correlate, I want to share with you. Suppose a patient comes to the emergency department and having asthma, and so in that situation, you will to reverse the bronchoconstriction because these drugs they are not going to reduce cardiac stimulating activity. Okay? Now the third group, etizantine. In the beginning, I told you the bronchodilators, beta-2-adrenergic agonists, second anti-muscarinic drugs, and the third one is the methyl. But clinically, in the current medical practice, we are not using this drug, right? There are some specific indications. For example, if COPD patient, right? The patient is not responding with bronchodilators like beta-2 adrenergic agonist or antimuscarinic agent, then we can try this. And second, if we are required the stimulation of diaphragm, then we can use it. Right? So specific. Why? Why we are not using this group? Because this group having low margin of therapeutic index. If we administer this group, we'll have to monitor the serum concentration of drug related to this. Right? So theophylline is the only member of this group, methylxanthine group, that is important to treat asthma. Theophylline is available in both prompt release and slow release forms. Mechanism of action, that is asthma is simple. What is the mechanism of action of methylxanthine group? So methylxanthines inhibit phosphodiesterase enzyme. So inhibition of this enzyme is going to raise the level of cyclic AMP. Increased level of cyclic AMP is required for the relaxation of the smooth. So we are required the high concentration of cyclic AMP. We are interested to relaxes the smooth. This phosphodiesterase enzyme that is going to break down the cyclic AMP and that will lead to decreased level of cyclic AMP. So that is why we are going to inhibit this enzyme. How we can inhibit? By giving inhibition of this phosphodiesterase. There is no degradation of cyclic AMP, so ultimately the level of cyclic AMP will raise, right? But this anti-phosphodiesterase effect, however, requires high concentration of the drug. And again, high concentration increase chances of side effects. So this is one of the reasons of not using commonly this drug. Methylxanthine also to produce bronchoconstriction. So these are the two probable mechanisms of action of methylxanthine. One is to raise the cyclic AMP level by inhibiting phosphodiesterase enzyme, and number two, blocking adenosine receptor. Right? Again, this is the diagram. You can see the red box. This theophylline, the negative sign indicates the inhibitory activity. Inhibit the phosphodiesterase enzyme, so there will be no degradation of cyclic AMP and ultimately raise level of cyclic AMP. And number two, it occupy the adenosine receptor, so adenosine now cannot bind with this receptor. So this is how we can avoid the constriction or contraction. Therapeutic uses: methylxanthine can be used to treat acute or chronic asthma that is unresponsive to beta-adrenoceptor agonists. They can be administered prophylactically. As though in the beginning already I told you, this group is not supposed to be the group of first choice. There are some specific reason to use this one. Okay? So these agents are used to treat chronic obstructive lung disease and emphysema. Methylxanthines are used to treat apnea in preterm infants based on stimulation of the central respiratory tract. So these are some specific indications where we can use this one. The common adverse effects of methylxanthine include gastrointestinal distress, tremor, and insomnia. Right? So severe nausea and vomiting, hypertension, cardiac arrhythmias, and seizures may result from overdose. And very large overdoses to attempt suicide are potentially lethal because of arrhythmias and beta blockers are useful in reversing severe cardiovascular toxicity from theophylline. This is important drug interactions and important reason of not using this drug. Commonly, theophylline is eliminated by P450 drug metabolizing enzymes in the liver. Clearance varies with age, highest in young adolescents. Smoking status, higher in smokers, and concurrent use of other drugs that inhibit or induce hepatic enzyme. Okay, this is the end of asthma 1. Can you hear my voice? Before starting the asthma 2, I just want to discuss the questions with my students so we can start the asthma 2 lecture in the continuation. Hello, can I talk to my host? Hello, or we should continue with second lecture, asthma 2. Okay, I think we should continue with second lecture. Hello, hello. Okay, should we continue this asthma 2? So already we have discussed the important drugs group like and some important side effects, important examples here. Examples of short-acting beta-adrenergic agonists, important examples of long-acting beta-adrenergic agonists. Okay, second group, anti-muscarinic drugs like ipratropium bromide, tiotropium, and what is the difference between ipratropium and tiotropium? Okay, so one of the students asked, okay, the side effects of theophylline. Important side effect that is related to the theophylline drug is the seizures and arrhythmia that may lead to death. Otherwise, it also disturbs the GIT status, right? Nausea, vomiting, but important side effects that can create the problem, that is the seizures and arrhythmia. Okay. Okay. So in the beginning, I told you the important phenomena which is involved is the process of inflammation. Okay, we have reversed the bronchoconstriction, but if we are not going to control the process of inflammation, the recurrences of bronchospasm potentially beneficial in severe asthma because of their toxicity, systemic or oral. That means either we are using glucocorticoids by parenteral route, right, or by using oral route. Because in both examples, drug will enter effect all over the body. That is called the systemic effect. So because of their toxicity, systemic corticosteroids are used chronically only when other therapies are unsuccessful. Inhaled corticosteroids have become common first-line therapy for individuals with moderate to severe asthma. right? Inhale, because it directly exposure of drug directly to the bronchial tree, right? So this is how we can minimize the systemic toxicity as well. Important intravenous corticosteroids that we can use for status asthmaticus or in emergency situation, right? Include prednisolone, which is the active metabolite of prednisone, and hydrocortisone. This we are using these two examples like prednisolone and hydrocortisone. We are using in our clinical setup in emergency situation. This is important. Inhale glucocorticoids uh, that you okay. Can you sir, we cannot see your slide. Please share your screen. Okay, now you can see. Okay, okay. Okay, so now we are going to start with the lecture two. So before starting this second portion, right? So I just want to revise few points, right? So what are those points? Uh, why it's not clear? I think. Can you hear me? Hello, hello, hello. Is it clear? It's breaking. Hello. Now it's clear. Hello. Is it clear? Hello. Okay. Thank you. Now it's clear. So before discussing second portion, asthma main process is involved, which is inflammation, and due to inflammatory mediators, bronchoconstriction. So in the acute attack, our main task is to reverse the bronchoconstriction to improve the air. But until or unless we are going to stop the process of inflammation, we cannot stop the recurrence of bronchoconstriction. So we stabilize our patient by using bronchodilators, and the first choice of bronchodilator beta-2-adrenergic agonist. So in emergency situation, short-acting beta-2-adrenergic agonist. If patient is not responding with beta-2-adrenergic, and we have short-acting anti-muscarinic agents, ipratropium bromide. Right now, the anti-inflammatory drugs, that is important. Right. So this is lecture two.
हेलो सर।
हेलो। हाँ, ये स्लाइड मूव क्यों नहीं कर रही?
लाइट मूव क्यों नहीं
हाँ,
हो गई?
अब हो गई, अब हो गई। चले,
ओके।
थैंक यू। आवाज सही आ रही है?
जी सर, थोड़े बच्चे कह रहे थे कि थोड़ी वो है, पॉज आ रहा है थोड़ा, बाकी अब ठीक है।
ठीक है, हाँ। चलें, सही है। Okay, in the second lecture, we are going to focus more on the anti-inflammatory drugs, and the major group is the corticosteroid, more specifically glucocorticoids. Because when we use the term corticosteroids, basically in corticosteroids we have two major groups: mineralocorticoids and glucocorticoids. So, more specifically, glucocorticoids related to corticosteroids are involved in the anti-inflammatory activity. So, second group is the mast cell stabilizers, and the third group is the anti-immunoglobulin E antibody. And the fourth group, in the beginning already we have discussed the leukotriene receptor antagonist. Right? Now, one by one, corticosteroids or glucocorticoids. So all the corticosteroids are potentially beneficial in severe asthma because of their toxicity, because we try to avoid the systemic use of glucocorticoids. Why? Because of its toxicity. When we say systemic, that means either we are using the drug by using parenteral route, okay, intravenous route, or other like intramuscular route or oral route. Because if you are using parenteral route or oral route, ultimately drug is reaching to the systemic circulation. So increased chances of systemic toxicity. So only we use systemic route when there is no response with inhaled corticosteroids. So that is why inhaled corticosteroids have become common first-line therapy for individuals with moderate to severe asthma. Because in inhaled, there is no drug reaching the systemic circulation. Because when we use inhaled route, drug directly reaches to the site of action, that is the bronchial. So this is how we can minimize the systemic side effects. But okay, local side effects definitely can produce, but that can be minimized. That we will discuss in the subsequent slide. Important intravenous corticosteroids for status asthmaticus or in emergency situation, right, include prednisolone, which is the active metabolite of prednisone, and hydrocortisone. And these two examples, these two intravenous preparations, you must know examples of inhaled glucocorticoids, right? Because these examples that we ask in the exam, what are the examples of inhaled glucocorticoids that we can use in the treatment of asthma? One is the beclomethasone, triamcinolone, budesonide, flunitrazide, fluticasone, and mometasone. And two important intravenous glucocorticoids that can be used in the emergency situation: prednisolone and hydrocortisone. Right. Mechanism of action: attenuating prostaglandin and leukotriene synthesis via inhibition of the phospholipase A2 reaction. Phospholipid barrier, phospholipid or lipid barrier, right? When phospholipase A2 enzymes act on this phospholipid, will be converted into arachidonic acid, and arachidonic acid will enter into two pathways: cyclooxygenase pathway and lipoxygenase pathway. Cyclooxygenase pathway is responsible to produce the different prostaglandins, and lipoxygenase pathway is responsible to produce leukotrienes. And leukotrienes, they are supposed to be the most powerful bronchoconstricting agent. The glucocorticoids, they are going to inhibit phospholipase A2 enzyme. So what will happen? When we inhibit phospholipase A2 enzyme, there will be no conversion of phospholipid into arachidonic acid. When there is no synthesis of arachidonic acid, there will be no formation of prostaglandin through cyclooxygenase pathway, and there is no formation of leukotrienes through lipoxygenase. Sympathomimetics and decrease mucus production, right? So this is important point. When we use long-term control medication, the group of first choice, glucocorticoids. This is important. And in when we use quick relief medication to control the acute attack, in that example, first choice would be short-acting beta-2-adrenergic agonist. When we use the long-term control medication here, the group of first choice would be glucocorticoids. This is important. And if we are using beta-adrenergic agonists, right? So it will produce maximum response in presence of glucocorticoids. This is important. If you are using long-acting beta-adrenergic agonist alone, increased chances of mortality, right? So along with beta-2 adrenergic agonist long-acting, so it would be helpful. Now you can see the mechanism of action for your dizziness. You can see phospholipase A2 is responsible to control cell membrane phospholipid into arachidonic acid, right? And arachidonic acid converted into two pathways, cyclooxygenase pathway and lipoxygenase pathway. And cyclooxygenase pathway is responsible to produce different prostaglandins, and lipoxygenase pathway is responsible to produce leukotrienes. And leukotrienes are supposed to be the powerful bronchoconstricting agent. Like here you can see leukotriene C4, leukotriene E4, leukotriene E4, that is responsible to produce bronchoconstriction, and leukotriene E4 stimulate the chemotactic activity, right? So why this diagram is important? Because if we stop formation of this arachidonic acid by inhibiting phospholipase A2 by using glucocorticoids, and glucocorticoids basically they are responsible to produce lipocortin, that is the protein that is responsible more specifically to inhibit the phospholipase A2 activity. Okay, so please remember, leukotrienes, they are powerful bronchoconstricting agent, and from where it is produced? From arachidonic. Through which pathway? Through lipoxygenase pathway. Clear? Okay. Use of inhaled glucocorticoid is recommended for the treatment of asthma prophylactic rather than to reverse an acute attack. This already we have discussed. In acute attack, we prefer to use the bronchodilator beta-adrenergic agent. Inhaled glucocorticoids that we use as long-term control medication or we use prophylactic. The most common adverse effects of inhaled glucocorticoids are hoarseness and oral candidiasis, right? Oral candida. But this can be prevented. How? If we advise our patient after taking inhaled glucocorticoids, if we wash our mouth properly, we can avoid this hoarseness and oral candida, right? The most serious adverse effects are adrenal suppression and osteoporosis. And when it will occur? It will occur when systemic treatment is required for more than 2 weeks, as in severe refractory asthma. Because this is one of the important advantage of inhaled glucocorticoids to minimize the systemic toxicity. So, no problem. Please don't confuse. These adrenal suppression and osteoporosis or skin thinning or cataract, all these are not the common side effects in inhaled glucocorticoids. Antagonists we are using for a prolonged period of time or increasing dose, then chances of these systemic side effects that can occur. Because of their systemic adverse effects, glucocorticoids are usually oral as well as systemic, right? Are usually reserved for patients with severe persistent asthma. Okay, if we are using glucocorticoids in any form, whether we are using inhaled glucocorticoids or systemic glucocorticoids, rapid may precipitate adrenal. So we are going to taper off the dose, gradually reducing the dose. Then we are going to stop the therapy. The regular use of inhaled steroids just cause mild growth retardation in children, but these children eventually reach full predicted uh, adult stage. So this is the main group when we say anti-inflammatory drugs, right? Main group that is we use as a long-term control medication. Where now the second group that can also be used, right? That is the mast cell stabilizer. Examples are bromelain and metochromate. And chromelin sodium, that is also called disodium chromoglycate, and nitochromil are unusually insoluble chemicals. So that even massive doses given orally or by aerosol result in minimal systemic blood level. Okay? They are given by aerosol for asthma and mechanism of action. It decreases the release of mediators such as leukotrienes and histamine from mast cells. The drugs have no bronchodilator action, but can prevent bronchoconstriction caused by a challenge with antigen to which the patient is allergic. Because they are not absorbed from the site of administration, so chromelin and nitochromil have only local effects, not the systemic effects. Clear? When administered orally, chromelin has some efficacy in preventing food allergy. This is another
एक्सक्यूज मी सर।
therapeutic use. Yes.
सर
Hello.
थोड़ी सी जी जी सर, कैसे हैं आप? कह रहे थे आपके ना
Uh,
असल में बैकग्राउंड में हल्का सा नॉइज है। खैर ये नॉइज चल जाएगा, लेकिन अगर थोड़ी सी आवाज़ आपकी बढ़ जाए, मतलब वॉल्यूम जो
अच्छा
है ना थोड़ा सा ज़्यादा हो जाए।
अच्छा देखें आ रही है आवाज
जी सर, आप सही है।
अब थोड़ी तेज हो रही है
जी जी, अभी
चलें
अच्छी सही आ
चलें
रही है।
चलें थैंक यू ओके so one of the important use of this mast cell stabilizers like bromelain has some efficacy in preventing food allergy. Similar actions have been demonstrated after local application in the conjunctiva and the nasopharynx for allergic immunoglobulin E mediated reactions in these tissues. So clinically, in especially in our setup, in the treatment of asthma, we are not using this chromelin and nosochromal preparation, but yes, in eye allergic reaction, in the eye we are using local preparation, right, of cell stabilizers. Like you can see the application of local application in the conjunctiva and the nasopharynx for allergic immunoglobulin E mediated reactions in these tissues. Bromelain and nitochromil may cause cough and irritation of the airway when given by aerosol. So these are the few points related to mast cell stabilizer. Now this is very important. So the major group is the uh, glucocorticoids, right? Inhale preparations that we prefer as a long-term control medication. Now this group, leukotriene modifiers. Why I have used this term leukotriene modifier. If you just go back and okay, now you can see this diagram. Now if you are going to focus on this diagram, arachidonic acid, already we have discussed, arachidonic acid enter into two pathways, right? Cyclooxygenase pathway and the lipoxygenase pathway. And already I told you, this lipoxygenase pathway is responsible to produce leukotrienes, like especially leukotriene C4, leukotriene D4, leukotriene E4. They are responsible to produce bronchoconstriction, right? So one of the phenomena to prevent the formation of leukotrienes could be uh, by using like okay here by inhibiting lipoxygenase pathway, by giving a drug that can inhibit lipoxygenase pathway. Okay? And another option is to block the activity of these leukotrienes by blocking the leukotriene receptors.